All right, guys, so now we're going to begin our discussion of the respiratory system. So, big thing to start off with is to note that the respiratory system is split into the upper respiratory system and the lower respiratory system. The upper respiratory tract includes the nose, nasal cavities, paranasal sinuses, the pharynx, and the larynx. Now, pharynx can be further subdivided into the nasopharynx, oropharynx, and laryngopharynx. And the larynx is normally what we would call our voice box. For the purpose of this lecture, know that these are areas where air can be brought into the body and they can enter the lower respiratory tract. I'm not going to spend much time talking about these areas. I would rather spend time discussing how the respiratory system actually functions. So the lower respiratory system, on the other hand, or the lower respiratory tract, begins with the trachea, the bronchial tree, and the lungs themselves. Okay, so once you get through the larynx and enter the trachea, that really is where the lower respiratory tract begins. So you'll see the trachea is a essentially tube that has C-shaped cartilaginous rings. They're C-shaped because the esophagus is on the posterior side, and if they were round all the way, it could impair the esophagus, considering they're right on each other's surfaces. As we get down into the lungs, you'll see that there's a split off of the trachea. And these are what you would call the primary bronchi. Okay? The primary bronchi, there is one for each lung. And that is very important to note. Now, the right lung and the left lung are going to have a different number of lobes. Okay? So this is primarily because the right lung is slightly larger, as the left lung has to accommodate space for the apex of the heart. Okay? So with the right lung having 3 lobes, our next bronchial split, the secondary bronchi, can also be called lobar bronchi. There are 3 of those in the right lung and only 2 of them in the left. Okay? Beyond the secondary, we then start to talk about the tertiary bronchi. Tertiary bronchi continue on. You get to the bronchioles. After the bronchiole, you get down to the alveoli. Specifically, it's respiratory bronchioles, alveolar ducts, and then the alveoli. Now, the lung, I believe, has branching of about 23-fold before you reach the alveoli. That means each time it splits, it does that 23 times. And you don't actually start to have gas exchange with respiratory bronchioles until somewhere around the 17th split. Okay? And it does this because it allows for a greater surface area of alveoli. Essentially, at the alveoli, though, we will have capillaries wrapped around. And this is where we tie ourselves back into the cardiovascular lecture, because the deoxygenated blood comes in and will release any gas waste here. So typically CO2. CO2 will enter the lung and leave via expiration, whereas the capillaries will then pick up oxygen. And this transition in the blood of oxygenated versus deoxygenated comes down to how hemoglobin behaves and how diffusion works. So the capillaries have a low level of CO2, so CO2 will enter, the capillaries here will have a high level of CO2. The alveoli has a low level of CO2. CO2 will want to diffuse out of the blood. Opposite is true for oxygen. There's a lot of it in the alveoli, very little in the blood. It will diffuse into the blood. And then it returns back eventually to the pulmonary veins, enters the left atrium, goes through the left ventricle, and then it's through to the systemic circulation. So when we talk about the lungs, a big part of the respiratory system is actually getting air into the lungs. So we see a couple different aspects of this. Our diaphragm, which you can see here, is outlined as a shadow. When the diaphragm contracts, it actually pushes down into the abdomen. So this contraction opens space for the lungs. And because of the way that the pressure works, the lungs are actually a lower pressure than the outside. This is going to cause the lungs to expand to fill that newly opened space. Okay? This allows air into the lungs. Now, we have other muscles that exist to help with inspiration. So, for instance, pectoralis minor can help elevate ribs 3 through 5. The external intercostals help to expand the rib cage. The sternocleidomastoid will pull up on both the sternum and the clavicle. And then we have the 3 scalenes of the neck, and the scalenes help to elevate the first 2 ribs. All of the action with the rib is going to help move the entire sternum out and up, which again expands the thoracic cavity even more to allow more air in. Now, all those muscles there are really only functioning with what you would call forced breathing. And that really only happens, if you're exercising and your respiration rate has to increase to keep up with oxygen demand. Other than that, though, the diaphragm really is the primary muscle. Now, we have the internal intercostals that exist. And internal intercostals will help to collapse the rib cage. Okay? So, it's going to help decrease volume. And then we have abdominal wall muscles that will also squeeze and pressure-wise force the diaphragm further up, which is going to reduce thoracic cavity space and less air in the lung. Now, as I mentioned before, the lung is at a slightly lesser pressure. So regular atmospheric pressure is 760 millimeters of mercury. The lung normally is at 756. Very small difference, but it is incredibly important to allow for inspiration of air to occur. And in fact, when a lung collapses, that's what happens when the pressures become equal. The lung will collapse in on itself. We can also see at the alveolar level collapsed alveoli due to much more smaller localized changes in pressure as well. But essentially, that action is how we see air coming in, air coming out. When you expand the space to give the lung more space, that pressure difference will draw in more air. And because the lung brings in very little air compared to the atmosphere, we're not changing atmospheric pressure. The lung will expand and fill with air. Now, respiratory control, again, primarily regulated by the nervous system. So the brainstem, in fact, controls a lot of this. So we see the medullary respiration centers. They kind of do accessory work with each other. They help control the musculature that expands the thoracic cavity. And again, the pressure difference, once the thoracic cavity expands, handles the rest. Okay? So when we expire, that air is forced out of the lung, and then we repeat on inspiration, volume expands, etc. So when we talk about the respiration, though, it's important to note that in the medical setting, we will measure various different volumes. They're going to be important for determining lung function. So a big thing to remember is tidal volume, which is the volume of air moved in or out of the lungs. There's the inspiratory reserve volume, which is the maximum volume of air that can be inhaled during resting inspiration. Then there's the expiratory reserve volume, which is the maximal amount of air that can be exhaled during resting expiration. Those three things are relatively good indicators of lung health. Okay, when we see issues with those, we can see problems with the ability to breathe. So going back to how we control respiration, though, right? A big control for it is actually increased carbon dioxide. And this is going to be detected by chemoreceptors. And these chemoreceptors are in the ventral respiratory group in the medulla. All right. What those do basically will trigger spinal cord motor neurons to activate respiratory muscles to a higher degree to increase ventilation. Also, with carbon dioxide, blood pH will drop. So this activates other receptors, particularly in the aorta or in the carotid arteries, which are important because the carotid arteries supply the brain. Those will be activated, and you'll see an increase in respiration because we need blood pH to stay standard. And what we see going on in the blood with dissolved CO2 is that an increased level in CO2 is actually going to cause excess hydrogen ions. Okay? So when we have bicarbonate in the blood, bicarbonate is actually going to essentially bind with carbon dioxide And that is going to end up creating carbonic acid. That's going to drop blood pH, right? So that's another indicator, blood pH again, for increase in respiration. And another thing to note, as we talked before, we talk about the transport of carbon dioxide and oxygen. It really depends on, essentially for gases, partial pressures and things of that nature, where diffusion is favorable to occur. So if carbon dioxide has bound to hemoglobin on the red blood cell, and we go to the tissue, let's say in this instance, somebody's exercising and the red blood cell enters into a muscle. Well, that muscle is going to have excess carbon dioxide. What's going to happen to the carbon dioxide in the red blood cell? It's going to stay on the red blood cell. It's not going to diffuse. But the red blood cell then will go to the alveoli. There's a low level of carbon dioxide in the alveoli. There's a high level of oxygen, and there's a favorable transfer that swaps the location of oxygen and carbon dioxide. Chemically, it can get relatively complex. We don't need you to really know, the chemical equations that you'll see in the textbook. Just know that essentially bicarbonate is important. Carbon dioxide reacting with water will form carbonic acid. And carbonic acid will dissociate into free hydrogen ions and bicarbonate. And the free hydrogen ions are essentially the main driver for the drop in pH, which again will trigger respiration.